that we haven't answered. And aside from that, Rich, thank you so much for being here. And welcome to Float Flag as always.
Never clapped before, President, because might not be very good. Anyway, thanks for the kind introduction, Brad. Want to thank Brad and Tammy for inviting me to come down and kind of share a bit of knowledge. I have some personal experience with IPE, some of it not very nice, but it gives me kind of an opportunity to kind of share a little bit about what I know. And in fact, although it has been around for a long time, it is an emerging problem because of the changing demographics and types of divers that we have right now are kind of creating conditions that it's perhaps more likely to happen than it was 40 or 50 years ago. And we'll talk a little bit about all the reasons why. I also want to thank all of you for coming out tonight, actually in person on the same night of a Stanley Cup playoff game. Montreal, the last time that happened, we actually moved the federal debate, right? For the hockey game. So I feel very blessed that you're all out here in person, you know. And I am a Habs fan as well. So if you're, on your phone and you find out that they've been scored against, please don't tell me because I won't make it through the rest of the seminar yet. My second favorite team is the Toronto Maple Leafs, and I'm still in mourning after the game last night too. So anyway, I also want to just recognize George Harper. Dr. Harper, some of you probably know him. You've met him before. He is kind of one of the foremost hyperbaric physicians in Canada, was responsible for bringing the very first recompression chamber to Tobermory, and has been an absolute fixture there. He first came to Tobermory in August of 1974, if you can believe that. Celebrated his first 50-year anniversary last year, which in fact is the same length of time that the Chichimon has been commissioned in Tobermory as well. It was put in the water in the spring of 1974. I actually started diving there in 1970, if you can believe that, when I was 3. So
nice.
They find tough crowd already. Anyway, tonight's seminar is about this issue called Immersion Pulmonary Edema. And I'm rightfully calling it an emerging risk factor. And by the time I'm done, I'm hoping that you'll see the reasons why. It's an emerging problem that perhaps you haven't heard about. And if you did, you think, well, it's very rare. And it is pretty rare. But in fact, we're seeing more and more of it over the last 20 years, basically. And it's because of the changing demographics of divers, changing fitness conditions, a lot of older divers that have pre-existing medical conditions, but they've been diving for 30 or 40 years. So they're like, yeah, I've been doing this forever. Just keep doing it and not really recognizing the potential impact. So my, now it's not working again, bro.
We'll get it. We'll get it. Don't worry. Try it now. Is it working? There you go.
So can you get rid of the bar on the top? What we're going to try to cover in the next 35 or 40 minutes is a little bit of a definition of immersion pulmonary edema, so that you know what it is and how to distinguish it from some of the other maladies that we have diving, right? Everybody knows about decompression things, but IPE is something very different. So a little bit about the basics of IPE. I always think it's nice to understand the physiological and physical reasons why some of these things happen. So we'll talk a little bit about basic human anatomy, and you'll kind of go away understanding the role of the heart and the lung, and the sort of effusion of fluids from the vascular system into the lung, which creates this issue. We'll spend a fair bit of time talking about predisposing factors because, as Brad said, something as simple as perhaps overhydrating can be a predisposing factor, but there's a whole host of other things that can exacerbate a medical condition and create the kind of primary conditions for a pulmonary edema episode. And you'll see a little bit by the time we're done that the significance of this is that early recognition often means the difference between life and death for the diver, okay? So not just for the person impacted, but for their buddy as well, to be able to recognize certain signs of distress in the other diver. They're very different from DCS issues, and understanding how those impact final outcomes. And then you're kind of going to say, well, what do we do if we see it? So we're going to talk a little bit about treatment strategies, because not always intuitive as well what to do in this particular situation. So almost everybody in here is probably taken first aid at some level.
Yeah.
If you have a visual distressed person, typically the recommendation is put them in a recovery position, right? That's the worst thing to do for an IPE case, and I'll explain the reasons why. So we're going to talk a little bit about, sorry, did you do that? You must have done that.
I think we're
Anyway,
under-
so
yeah, my apologies.
treatment strategies. And then, as I always like to do in all of my lectures, some take-home points. So in 2 weeks, if you remember nothing else other than 3 or 4 take-home points from that, then I'm kind of happy. Okay, so that's kind of the outline for the talk. IPE basics. If you go away and you say, well, that was pretty interesting, I think I'm going to Google and read up on that. You're going to find IPE described in a couple of different ways. IPE, immersion pulmonary edema. Also, there is another medical spelling of edema that starts with the letter O. So it might be listed as immersion pulmonary edema. Okay. Most of the British literature, for example, there's been a lot of work done on IPE in Europe. So you'll see all of that literature is listed as IPO. And then there's another kind of nomenclature that you'll start to see now called ROPE, which just means rapid onset pulmonary edema. They're basically all the same thing. So if you're reading about one and you think, I wonder if that's the same as what Rich was talking about on IPE, in fact, they are all the same physiological symptom, okay? IPE really is a type of internal drowning. And you'll see by the time we're done tonight that it really results from leakage of plasma from the blood vessels into the alveolar air spaces in the lung, which basically impairs oxygen uptake and getting rid of carbon dioxide, putting a diver into a critical hypoxic situation, which ultimately can lead to their death. So it occurs when there's an imbalance between the fluid that's flooding into the lungs relative to what's flooding out of the lungs. And I'll have a schematic next to talk about the anatomy of the vasculature system, and then the relationship between the heart as a pump and the lungs, and where the actual effusion or leakage of blood plasma occurs. There's a whole pile of different contributing factors. Some of them are now fairly well understood, and many of them are not that well understood. And we're learning more and more about the predisposing factors for IPE as we see more and more cases of it. It's an interesting phenomenon. I'll tell you later about some of the early diagnoses of IPE. And in fact, the very first discovery of it was in young, highly fit males, Navy SEAL divers. Okay. That was the very first occurrence of IPE were in Navy SEALs. And you say, well, who could be more fit than that, than a Navy SEAL? But if you see what they put them through in terms of physical exertion in cold water with unnecessary, thermal control mechanisms, and you can understand how they are pushed to the very limit of physical capability, right? So, in fact, it was first observed in Navy SEALs, surprisingly enough. And the fluid shift, or that effusion of blood plasma into the alveolar lung space, really is thought to be contributed in a major way by immersion in water. So it's why we don't have pulmonary edema now in the things that we do. If I have a really hard day in the gym pedaling on a bike and, got my heart rate going, I'm not going to suffer from pulmonary edema in that situation. Immersion in water is a sort of a major factor that contributes. And of course, that's where it got its name, immersion pulmonary edema. Okay, so that's a little bit of the basics of IPE. Who could it happen to? We're talking about divers and the diving industry, but in fact, it is not an uncommon finding in swimmers, snorkelers, free divers, triathletes. In fact, in the water swim portion of a number of triathlons have experienced immersion pulmonary edema. And you'll understand the reasons why when we get to the end of the lecture, because they are also subjected to that intense physical exercise, immersion in often cold water conditions, wearing fairly snug suits, right, that can constrain and restrain their ability to breathe properly, because they're sort of at almost maximum athletic performance in the swim portion of a triathlon. And they have actually had fatalities in triathletes, young triathletes, right? 25, 30-year-old triathletes died from immersion pulmonary edema. We've also seen and starting to see an increase in snorkelers. And we'll talk about the reasons why too. You say, well, that's a pretty benign activity, snorkeling, right? Everybody kind of can do that. But in actual fact, there are relative factors in snorkelers now that are predisposing to IPE. So take-home message about that is, if you kind of happen to anybody in any situation when they jump in the water and become immersed. Okay? All right, let's do a little bit of a human anatomy review here, just so that you can kind of understand the kind of physics and physiology of what's happening. This is a person here, their lower body here, legs down, and obviously the upper body there. You see the lungs, left lung and right lung, and obviously this is the heart pump in the middle. So we'll just kind of follow a little parcel of blood as it moves around through the system. And we'll start at this location here, number 1. That's the right ventricle in the heart. So this then pumps blood up into here in the 2 pulmonary arteries and feeds relatively lower oxygenated blood that's returned from the rest of the body into both lungs, all right? The primary role of lungs is to both offload carbon dioxide, which is the primary metabolic end product of aerobic respiration. So when you move your muscle like that, you're using energy sources that are used oxygen to produce that energy. And the end result is you produce carbon dioxide. So the lungs, in fact, have a double role. They do lots of other things too, but their 2 primary roles are to get rid of carbon dioxide. So when we breathe out, we're breathing out carbon dioxide, and to also then allow the exchange of oxygen from the air that we breathe on intake to then pass the blood air boundary and get into the blood to resupply the rest of the body. So the blue kind of is the lower oxygenated blood, right? Now, always remember in first aid, right? If you cut something and it's like quite dark blood, that's probably venous blood and you don't panic so much. If you cut something and it squirts and it's brighter cherry red, that's arterial blood, very highly oxygenated, and that's probably something that needs a bit more attention, right? Get compression on it and deal with that. So as this lower oxygenated blood then is fed to both of the lungs, it then picks up oxygen. And the red blood cells in your bloodstream have hemoglobin in them, and those are the chemical things that bond oxygen to the red blood cell, which then takes it out to the rest of the body. So now we've changed the color here from blue to kind of red. The blood then comes back from both the left and right lung through the pulmonary vein back into the left atrium. Okay, so standing this way, left atrium, into the left ventricle here, and then that pumps highly oxygenated blood out to the rest of the entire body, right? There's a major one vein or artery that goes to the brain, which of course is the bad location for an embolism, right? That's how come you oftentimes will get arterial gas embolism, will go right to the brain because it goes up this major artery here. And then the rest of the body, all of the internal organs are also then fed with that highly oxygenated blood that comes from the lung. After going through all the rest of the tissues in the body, of course, then you have a reduction in oxygen in the blood and an increase in carbon dioxide, and then that then returns back to the right atrium and begins that cycle all over again. If you know pumping and hydraulics, think of this exactly as a pumped hydraulic closed system, all right? So when these chambers beat, they beat in synchrony to move fluid, the blood, around through the system. So a beat here causes change in blood pressure and blood flow down here. There are one-way valves and back check valves all through the system as well, so that the blood goes in the right direction, just like in a hydraulic system. And it's quite an exquisite mechanism, actually, that is very precisely timed with the beating of the heart and the 4 chambers of the heart, right? So, you know, when you listen, you put your ear against somebody's chest, you hear that kind of lub-dub, lub-dub, lub-dub. Well, that's those 2 chambers beating just a little bit out of sync as they're moving blood through the system. So that's kind of a little bit of an overview of the sort of physiology and anatomy of the vasculature system. So the important part to focus in on now is right here, okay? So immersion pulmonary edema impacts the lungs. That's where the pulmonary word comes from. And essentially what happens is you have leakage of blood plasma as this blood supply is coming back from the rest of the body, leaking blood plasma into the alveolar airspace in the lung. So it's sort of equivalent to inhaling water, except you're not inhaling external liquid, you're inhaling or having accumulation of blood plasma from your own blood supply. So that's why we term it an internal type of drowning. And schematically, I guess it's all about sort of the differential rates of fluid that go to the lung versus how much goes out of the lung. So this guy here is obviously got a hole in the boat and he's bailing as fast as he can, but there's more fluid coming into the boat than is being bailed out. And that analogy then can just be thought of exactly the same in the lung. There's more fluid that's flooding into the alveolar airspace than is being extracted out. And so liquid accumulates, all right? This is sort of a schematic, but an X-ray looks a little bit similar sometimes to this. So a normal lung over here, you kind of have all the vasculature space here and the bronchioles and the fine air spaces that feed into the lung. And over on this side, you'll see that much of the tissue mass of the lung, in this case here, has got this material, which is really fluid in there. And so if you imagine the lung being a very thin cellular layer with air on one side and blood on the other, as the heart is pumping blood through the lung, the carbon dioxide diffuses from the blood into the airspace, and oxygen diffuses back across in the other direction, and then feeds the red blood cell, the hemoglobin in there, which then ultimately takes that oxygen around through the rest of the system. So if you add water, or in this case, blood plasma into that system, where you should have an airspace on one side of the alveolar membrane, you now have fluid that accumulates. What does that do? Well, it slows down the rate of gas transfer in both directions. So your body builds up carbon dioxide and it reduces the oxygen transfer from the air that you're breathing in across that cellular, very thin cellular membrane in the lung, getting into the red blood cell. So essentially, the end result in IPE is that you are drastically reducing the transfer of oxygen from the air that you inspire to your red blood cells, okay? And once it gets severe enough, then you become hypoxic. And you can be a little bit hypoxic or a lot hypoxic, and you eventually can get to the point where you become anoxic, and that's where death is going to happen at that point, okay? So try to give you a little sense of how the anatomy of the heart-lung relationship then can sort of lead to fluid accumulation, which ultimately then just becomes a matter of gas transfer physics is really all it is. Oxygen can't diffuse well enough into the bloodstream and can't then supply the rest of your tissues around your body. So that's kind of the overall story of that one. Now,
You tell me when to hit play now.
yeah, so I don't know how many people were here for the OPP lecture. Anybody? You know, they had all this like really cool equipment that they brought and they were showing all this stuff and you ran up. I got nothing other than a condom here that I've got in here, so full of water. And if you press play, you're going to watch the condom being lowered down into this small vase of water. And you see what happens, pushes water out the top, which of course is no surprise to anybody, right? But why does that happen? It happens because the hydrostatic pressure at the bottom of that water-filled balloon or condom is greater than at the top. And so as you lower it down, that hydrostatic pressure pushes the water, the fluid, out the top of the condom. That's exactly what happens in a vertical orientation posture when you're submersed, okay, immersed in water. And I'll show you a picture in a second of the differential between a diver in a horizontal attitude versus one in a vertical attitude. And you might say, well, how could that make much of a difference, right? But we'll show you the math and how that actually can make a pretty significant difference. So this is just a thing to kind of remember about hydrostatic water pressure and how it can move fluid. I mean, he's only lowering that thing a few centimeters down into the bucket, yet that's enough pressure differential to force that water pretty, hard and expelled out the top, right? So kind of remember that concept as well. Okay, triggering mechanisms. Why do George and I call this an emerging problem, right? Yeah, was it around 50 years ago? Probably, yes. But it's more common now, and we're seeing it in more situations than ever before. So the mechanisms that trigger it, pretty complex. Some of them we know, some of them we don't know. We do know a couple of things, that physical activity, and it can either be intense physical activity by a highly conditioned athlete, right, like a triathlete, or it can be modest physical activity by somebody who's not in such great shape, right? So, you know, we've got a mix of individuals in here. Some might have better cardiovascular conditioning than others. If we went outside and had to run 100 meters, you know, at a slow pace, some wouldn't make it, be puffing quite a bit. Others would be ripping down that 100 meters, no problem. So when I say intense physical exercise here, that's very individual specific, basically, right? So that's one. And then an increase in negative ventilatory pressure is also a very significant factor. And a couple of examples of this, and we'll talk later, but if you have a regulator which is not tuned properly and you're really having to hoof on it to inspire, right? I mean, maybe not that hard, but you know, where you've got a fair bit of inspirational negative pressure that you have to create, that's creating quite a negative pressure in that airspace, in that alveolar space. And what that does is actually then increases the rate of fluid transfer across that semi-permeable cellular membrane in the lung, and can then increase fluid accumulation in the lung. So high inspiration pressures from badly tuned regulators and somebody who's not so physically fit with some of the other factors here definitely can be predisposing to that. Other things, I don't know how many people are dive rebreathers. Not too many here. Okay, but back-mounted rebreathers, for example, they're seeing more issues of IPEs in back-mounted ones because in a normal horizontal trim, right, you've got more pressure on your ventral side than you do on your dorsal side and causing higher inspirational pressures, right? And when I first started diving, of course, it was twin hose, single stage on the tank. And, you know, we really had to hoof on that most of the time to get sort of good breaths, particularly at depth. So there's a couple of these variables that are working in concert with one another that essentially increase the negative vacuum pressure in the airspace in the alveoli. And that then works to kind of draw fluid in a more pronounced way from the vasculature space. We also find, and this is where some of the changing demographics, you know, we have an older dive community now than we did 50 years ago. There's no question. I mean, when I first started diving, which was 54 years ago, everybody was young, highly fit, a bit of a cowboy. And once you were like about 40 years old, you weren't diving anymore, right? I mean, there were some, but typically it was a fairly young, fairly fit group of divers. Now it's kind of completely the opposite, right? We have an aging demographic. People are diving into their 60s, 70s, 80s. A lot of them with other sort of underlying medical issues as well that they've been able to cope with for 30 years. You know, yeah, I got a bit of a problem in my heart, but I've been diving for 30 years and I'm fine. And then eventually you're not fine because those are exacerbating factors to provoke IPE. So we know now among the older divers, and we're saying older here being kind of the 50, 55-year-old and up, that kind of category, right? I'm not saying that's old.
We're almost there, Rich.
Yeah, we are, aren't we, Brad? Yeah, next year. I turn 55 next week myself. But anyway, so in that older group of divers, we know actually almost a third of them now have some form of mild to moderate underlying cardiovascular risk factor. That's pretty significant, right? Particularly when you look at the mechanics of what provokes IPE, primarily related to cardiac and pulmonary function. This is an interesting one. Not really borne out 100% yet by statistics, but it appears that women are more susceptible to IPE than men. And I don't really know the reason why, but it's been postulated that, you know, women typically for the same body size will have a slightly smaller lung volume. And they also do have narrower bronchial pathways in their lung as well, which is why in aerobic events at elite level, men always will outperform women most of the time, not necessarily other than the fact that they have a higher cardiovascular and pulmonary capacity than women. And this then can create a bit of a potential factor for why women may be more susceptible to IPE than men, okay? Men are too, but definitely they're seeing a little bit more pronounced prevalence in females here. So let's look now at some of the predisposing factors and try to justify my statement about it being emerging. So this guy here, you know, I want to be free to be me. Fair enough. drinking beer, chained to the couch, morbidly obese, smoker, in drinking alcohol, yada, yada, yada. That's fine. Not making any judgments, but maybe that guy shouldn't be diving, right? Because of those predisposing factors. And of course, this is not an absolute all or none thing. You know, not everybody ends up looking like this and is diving, but there is a progression, right? As you get older, you get a little bit more out of shape, you put a little bit more weight on, you maybe have some bad habits, you maybe have, you know, some early signs of coronary artery disease, which is common, you know, in 65, 70-year-old people, you see this a little bit. So these things can be precipitating factors. So anything that impacts heart disease, of course, now you see the anatomy, that's got to be a predisposing factor. Renal disease, which causes hypertension in the vasculature system, because so much of the blood has to pass through the kidney. Same thing with liver disease. Obesity is now known to be a major contributing factor, and we'll talk a little bit about that. Brad mentioned hyperhydration. And if you sat in on Neil Pollock's talk a month ago, he also mentioned about hyperhydration being an issue. And this is one here again that wasn't intuitive, right? We always used to say, make sure you get really well hydrated. You know, and the only reason that you didn't was because you had to pee in your wetsuit or your dry suit or whatever. So you kind of limited your fluid intake. But now we know that hyperhydration actually can create a problem because you're increasing the blood volume, right? When you hyperhydrate, you increase your volume of blood in your system. That then produces more workload on the heart. You've got more fluid that has to pump through that elaborate system of veins and arteries and through the lung. And so hyperhydration is actually known now to be a fairly significant factor in precipitating IPE. And then any other medical conditions that cause hypertension, again, common in aging divers, right? A lot of people, their blood pressure is kind of getting up there a little bit. You're maybe only at the type 1 level, you know, maybe around 135, 140. So not too bad, you know, if you're 60, 65, but, you know, you're starting to be a little hypertensive. You get up a little bit more than that. Now you might be in that category of increased risk factor for IPE. Some of the other predisposing factors that impair lung efficiency. So we talked about things that then impair the movement of fluid through the vasculature system, things that impair the efficiency of lung. Obviously, chronic obstructive pulmonary disease. I mean, you don't need to be a rocket scientist to think if you have obstructive pulmonary issues, that's going to increase the workload of the heart trying to move blood through the lung. Smoking, for a number of reasons, but one of the big ones is that smoking lowers your oxygen carrying capacity in your red blood cells. So a normal smoker will carry a little bit less oxygen through the system than a non-smoker. And if you're sort of sitting on that marginal bubble category of things, that could be enough to kind of trigger it over. Pulmonary fibrosis, again, that really is the increased rigidity in the lung. So it doesn't have the ability to be elastic as much as it should. And that will increase the pressure of the blood moving through the lung space. This is an interesting one, anemia, because anemia can be present, sort of variable in people, right? You can be fine, and then you might have a bit of anemia, and then you're fine again for a variety of different reasons. I mean, you know, obviously blood loss, you know, nutrition intake, are you getting enough iron? Various things can lead to anemia. And anemia really is either a low red blood cell count or low hemoglobin, okay? So hemoglobin is that chemical compound which is responsible for binding oxygen and carbon dioxide and transporting it from the lung to the tissues. And that's how you basically can continue to exercise and do work and your body functions. It's really the carrying capacity of the red blood cells and the chemical compound inside called hemoglobin, which moves oxygen. So, you know, if you have a blood analysis done and your clinical chemistry comes back and it goes, yeah, you're a little bit, you know, low, pretty marginal, you know, your red blood cell count's down, your hemoglobin is low for whatever reason. Maybe you don't have enough iron in your diet. Maybe you've got internal bleeding from something else, lots of different reasons. This also can be an exacerbating factor. Why? Because you're carrying less oxygen to your tissues, right? You're already a little bit hypoxic, if you will. And then if the other issues and predisposing factors kind of come to play, then this can be kind of a significant one. Age-related decrease in vital capacity. Vital capacity is really defined as the maximum amount of air that you can expel, taking the deepest breath you can and the hardest complete expiration, right? So I don't know, last time I had mine done when I was a varsity athlete, it was a little over 6 liters. That was my vital capacity, right? So if I took a full breath in, blew out as hard as I could, I would blow up a 6-liter volume of air. That's called vital capacity. Well, that declines as you age, right? So I don't know what mine is now. It's probably more like 4.5 or 5, something like that. So it's a little bit less than it was when I was younger. And all that means is that your lungs are not as efficient because they're not moving as much air in and out. So they're not supplying as much oxygen and they're not removing as much carbon dioxide because the ventilatory rate changes with the vital capacity being reduced. Another aging issue is the decreased heart muscle strength. I don't know if people work out, you know that, arbitrarily they say, well, take 220 minus your age, and that roughly will be what your maximum heart rate should be achievable to be. So, if you're 60 years old, it means you should be able to achieve in reasonable cardiovascular condition a heart rate of about 160. Now, if you're a really finely tuned athlete, you can maybe get 170, 175, but you won't get up to 200 like you would have when you were 20, right? Because the heart muscle itself reduces in strength. It's a muscle that essentially, atrophies a bit over time, even though it's beating all the time. And so you combine all these things, decreased heart muscle strength, age-related decrease in vital capacity, clearly aging, fitness, and relative level of conditioning changes as we age as well. All these things can, again, be predisposing factors. Well, what are things that can impair the workload or increase the workload of breathing? So we looked at things that can impair the movement of fluid, things that can impair the functional efficiency of the heart, things that can impact the lung efficiency, well, things that increase the workload of breathing. If you have a really tight wetsuit, and I see this all the time as a dive boat captain, right? People rent wetsuits or they have one and it's too small. They put on, 20 or 30 pounds now. It doesn't fit so well anymore. And they're like, it's so tight, all the time, right? Well, if that's causing constriction of your thorax, the central part of your body, to breathe, you have to inhale harder, right? And when you inhale harder, you increase the negative inspiratory pressure, which then can pull more blood plasma across that alveolar membrane into the airspace. So tight wetsuits, and this has been identified quite a bit in surface swimmers, not divers, not snorkelers, just people surface swimming, these triathletes sometimes, right? Poor regulator maintenance, we talked about. If you have, not optimal kind of intermediary pressure on your regs and you're having to inspire like way too hard, or maybe you have a reg that isn't that efficient at depth and you tend to be diving a little bit deeper all the time and you're having to really drag air in as the air density increases with depth. All these things then effectively do the same thing in the lung, increase the negative inspiration pressure in the airspace, which then can pull more plasma fluid from the blood system into the lung. Okay, postural attitude in the water. So pulmonary edema we talked about. Postural attitude, let's have a look at that. So here's 2 divers. One you got, yes. So
that.
both of them, and it's good not to say who they are.
I remember
I'm the
when
guy
that
in the
was
left.
posted.
Yeah. Anyway, we got 2 divers here. One in pretty optimal horizontal trim, right? The other in obviously more vertical trim. And you might say, well, okay, how that's a big deal. Well, this individual is over 2 meters tall, right? So his feet are 2 meters below his head, right? So what percentage of an atmosphere is that? Come on.
7 feet.
Hmm?
Almost 7 feet.
Well, you got an atmosphere is 10 meters, right?
So it's about 20%.
20%. So if you take that in terms, I don't know if you're thinking bar or PSI or whatever, but that's a few PSI, right? 20% of 14.7, whatever, is about 3 PSI. That's pretty significant. If you actually had to try to blow 3 PSI out, that takes a bit of effort. So the actual difference in hydrostatic pressure between the feet And the heart-lung space up here is actually fairly significant in a vertical orientation like that, which is why from IPE regulation, you're going to see that one of the recommendations obviously is trying to maintain decent horizontal trim, particularly when you're surfacing. And we'll explain the reason why in a little bit. So the take-home message here is that perhaps this diver on the right is going to be more susceptible to IPE than the one on the left, because this diver over here is not exposed to differential hydrostatic pressure from feet to lung.
It's like the movie you showed earlier.
Yeah.
Right? That's really what it is.
Okay, so just kind of an example of something as simple as trim and in-water posture can actually then exacerbate the inspiration pressures and the differential hydrostatic pressure, which then can promote immersion pulmonary edema.
Rich, correct me if I'm wrong. Also with technical diving, they're now saying gas density is also a key factor here in work of breathing, which
Yes,
can cause that same negative inspirational
absolutely,
pressure.
yeah.
But that's more tech people diving helium.
It is, and we didn't really
mixes
want to
and
get
stuff.
into that one.
Yeah, but
That's
just
quite right.
for general interest,
Yep.
that's another thing that doesn't tend to fall into this
Right.
recreational realm, but is a bigger part of technical diving now.
No, very good point. And the things are not always so intuitive, right? Like you kind of don't necessarily think like, well, this can be a predisposing factor, you know, just by the way I'm trimmed in the water. Why would that be an issue for IPE? Well, you're seeing how it is. Things that increase cardiac workload. Well, we've already talked about some of them. Having that hydrostatic or hydraulic pumping system that I talked about. You know, if you have a garden hose and you put your finger over the end, what happens? Pressure increases right away, right? Because you're restricting the outlet diameter of the hose, and behind the restriction, the pressure goes way up, okay? And that can happen in a human when your arteries start to harden, if you have plaque formation and reduction in your artery size, right? So again, as you get a bit older, it's normal to have, you know, 5, 10, 15, maybe even 20% sort of occlusion in your main coronary arteries. You know, that's still not too bad. But if you have that, then that means you've got like a little finger over the edge of the garden hose in your workload that you're adding to the heart. So some of these things here will then impact on how hard the heart has to work as a pump to move systems blood through your lungs. That then all increases the blood pressure in the lung area, which then means the blood on this side of that semi-permeable membrane is pushing a lot harder against the airspace on the other side, which then promotes leakage of the plasma over. So this is just a sign here of what, you know, fatty plaque accumulation will look like in a coronary artery or whatever. Here's a normal one over here. This is a little bit of a occlusion, a little bit more, a little bit more, a little bit more. And, you know, by the time you get to this, and you might have a heart attack, or you might have one down here too. But, you know, the whole idea of that you're blocking off the easy flow of blood through the system. So these things can then increase cardiac workload. So we've seen sort of now a whole suite of factors that can impact on cardiac efficiency, pulmonary efficiency, workload of breathing, you know, constriction on your lung. Wetsuits we talked about already. We're going to talk briefly about anxiety and anticipation stress. Certainly a cold environment is known to be exacerbating as well because it causes vasodilation or vasoconstriction, sorry, right? So you jump in the water, your peripheral blood vessels start to kind of squeeze down, which is why your hands and your feet always get cold first, because your body is saying, uh-oh, I'm going to be losing heat in an awful hurry here. I'm going to shunt that blood to my core because I got to protect my heart. I got to protect my brain. So, you know, the endocrine system in your body then is shunting blood to try to save your life. But on the other hand, when it shunts all that blood to your core, it increases both the volume of blood around your heart lung as well as the blood pressure, right? So again, exacerbating factors. And the peripheral vasoconstriction is something which happens in cold environments. Now let's have a look at this kind of role of anxiety. Obviously, divers can be anxious for lots of different reasons, right? Lack of training, you're tired, it's a dive site you're not familiar with, there's current, you're in a new dive buddy, you don't know how that's going to kind of work out for you. all kinds of different things, right? You had an argument with your partner the night before, you're just feeling whatever. Anxiety can be a real issue. And in an extreme case, of course, I don't know if you've ever had an anxiety attack, but an anxiety attack is really an extreme presentation of anxiety and hormone production in your body, which can produce, rapid heart rate, right? Breathing, perspiration. You feel like you're going to have a heart attack, and sometimes hard to distinguish between an anxiety attack and a heart attack. The symptoms are very similar. So all these things then kind of can create anxiety in a diver. And one of the things from an endocrine point of view, the body will produce high levels of adrenaline, the fight or flight hormone, right? And of course, if you've ever, if you've been, like last night, I was in the bar having beer and chicken wings watching the hockey game, right? And there were some Sens fans there, and there were a bunch of Leaf fans there. And of course, the chirping was going back and forth for a while, and people were starting to get pretty excited, right? Especially when the Sens scored their third goal. And that produced adrenaline. People get pumped up, they might argue with you, they want to fight or whatever. So adrenaline is one of the sort of downstream endocrine effects of anxiety. That has an activation on what's called the sympathetic nervous system in the body. And the end result of that is that it causes vasoconstriction and increases heart rate, right? So that's why, if you're having an anxiety attack, your heart's beating like crazy, right? That's common. I don't know, I grew up Italian in a Ukrainian neighborhood, so I did a fair bit of scrapping until I was about 15. But, anytime you had a threat that was presented to you, adrenaline got you ready to scrap, right? Your heart rate's going quicker, you get oxygen all through your system. So all of these things, in fact, exacerbate and are predisposing to IPE for all the reasons that we've talked about before. Really just increasing that rate of effusion of fluid from the blood into the airspace. Internal drowning, we call it, right? So what's the classic history in people that we know have suffered from it and either lived or not? There seems to be a few things which kind of are gold standards, if you will, that seem to happen all the time. So often there's misgivings or a feeling of unwell prior to the dive. And of course, what's the common end result of that? You're anxious, right? Mm-hmm. So your anxiety level is higher. And that can be for all kinds of different reasons, but often people that have had IPE episodes have then reported afterwards that, I wasn't feeling like I should have dove, but I did. And we paid all this money to come up and didn't want to let my buddy down, yada, 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 right? So you've got these feelings of unwell. The other thing that's quite interesting here is that the trouble with IPE starts very early in the dive, usually within the first 5 or 10 minutes, not after an hour. Right? And it's not just because, you've gone deep or whatever. In fact, it's more likely to happen in the shallower part of the dive because it's the early part of the dive as well, where, of course, the differential hydrostatic pressure is the greatest, right? So if you're in the top 10 meters of water, you're now experiencing on your body the more pronounced hydrostatic difference in pressure. So first 5 to 10 minutes. And this, I have no idea. And, George doesn't have a thought either, but it seems in a number of the cases, the males seem to have the problem earlier. And I don't really know why, and this may be even a false statistic, right? But it's something that was coming up in the data set that there seem to be more males responding early in the dive than females. One of the things also that you kind of see in the pattern here is when people start to experience this breathing difficulty, basically, their immediate thought is that there's something wrong with their gear, right? Their rig's not working properly. I don't know, it's not adjusted. They're fussing with the valve on there, wondering, and then you kind of watch them and you'll see like, it's kind of weird, you're not behaving quite normally on things. Or they might even be making sort of confused or inappropriate responses to things, right? You might give them a sign for something and they might not respond properly. They're confused, but they otherwise look normal, nothing major wrong, and they're not giving you the something's wrong with me sign or whatever, but this seems to be something that happens in the history. And then, of course, later on, and you'll see shortly, this can progress very rapidly to extreme hypoxia, which leads to unconsciousness, and that happens in the water. Of course, the outcome is bad, right? So And in extreme cases, you can see hypoxic convulsions as well. So just a quick slide here just to kind of prove the point about emergent problem that we're seeing here. Trends in divers, 26% of divers right now are 50 years and older. And that's statistics from Dan and Tobermory that George has been keeping track of over the years. You've got a fairly significant number of them that have different kinds of allergies, hypertension, asthma, heart disease, underlying, right? Not necessarily like you're going to drop dead from a heart attack, but you've got underlying cardiac inefficiency there that can sort of lead to that problem. Okay, so this is just sort of making the point that this group of divers is very different than 40, 50 years ago. So that these predisposing variables are perhaps more important now than they were before. This is a big one. Partly because obesity itself is related to the workload on the heart. So the more obese you are, the harder your heart has to work to pump blood all through that extra tissue in your body, basically, right? But also obesity often comes hand in hand with diabetes and other underlying medical issues. And so this is just looking at the obesity trends using a very crude index, I'll admit, called body mass index, which is just a ratio between your height and your weight. So it's not a perfect index for obesity, but anything kind of less than 25 is considered to be pretty normal. 25 to 30 is maybe just a tad bit overweight. 30 to 35 is obese, and 35, 40 and up is considered to be morbidly obese, right? So that's a very, very heavy individual that would have a body mass index of 40, for example. Now, as a boat captain, I can tell you, I see a lot of people up here. And there have been many times where I literally didn't want to take them out diving. And they were very experienced divers, some of them, right? But they were morbidly obese. So that's like a ticking time bomb for something to happen. And the most likely outcome, obviously, is coronary collapse, right? Heart issue. But we're also seeing obesity now very much trending along with IPE for all the reasons that we've just talked about. All right, signs and symptoms of IPE. So what's the difference between a sign or a symptom? A symptom is something that you can perceive in yourself. I feel hot. I got a headache. I'm flushed. My stomach hurts. My elbow hurts or whatever. That's a symptom. That's something that I can express to you. A sign is something that an observer sees in you, right? I'm looking at you like, well, you're looking pretty red in the face there, right? Or you're pretty fidgety or whatever, right? So there's a difference between signs and symptoms, okay? Usually we just call them all symptoms, but in fact, it's important because I want you to remember things that you can observe in yourself as potential predisposing, events to IPE, and things that you should recognize in another diver, right? So that's why I'm talking about signs and symptoms. So signs are something that you observe, symptoms are something that you feel in yourself. So what are some observer signs of IPE? Okay. Well, I'm looking at Brad and his breathing's pretty labored, He's like, oh God. Kind of labored breathing, right? Can take all different forms, but that unusual anxiety or apprehension. That guy's been diving for 4 decades, got thousands and thousands of dives, but today he's really acting kind of funny. Something kind of funny there. These ones are real telltales. Gurgling breathing sounds. Well, again, you don't need to be a doctor to kind of figure that one out, right? If you got a liquid in your lung, when you're breathing, you're going to hear gurgling sounds in your lung. Coughing. You told me you were perfectly healthy before the dive. Now you're coughing like crazy. And you might be coughing in the water. How many people have done that? Yeah. Me too, actually. I had a couple of dives where I was like, I'm trying to clear my lungs and, yeah, I'm okay. Keep diving, right? Probably had a little bit of IPE maybe in that situation. So coughing is a major one. Foamy or frothy sputum. So, you come back from a dive and you're back on the boat or you're at the surface of the water and, it's typical for people to spit a bit of sputum out, but now it's a lot, right? And it's foamy like whipped cream that's been beat like that. And it's the protein in that plasma that's leaked into your lung that now you're bringing it up and you're kind of spitting it out, trying to get rid of it because you're trying to void that material in your lung because you've been having problems breathing. Pink tinged sputum is also a bit of a dead giveaway because that means that some of the very fine capillaries in that alveolar space have ruptured. And now you've got red blood cells that have leaked into that fluid in your lung and you're spitting that up. It doesn't look like really red like that. It's just like a very faint pink, maybe more like the can. They're not even that pink, but you kind of really say, well, that's unusual, like you're coughing, you're spitting up pinky sputum. You were perfectly healthy before the dive, right? These are all things I'm recognizing in my buddy. Cyanotic, well, they're starting to turn blue. Okay, that's a pretty bad sign. And in an extreme case, usually they don't end up on the boat with this. This happens in the water where they have hypoxic convulsions in the water. And typically the outcome is bad if that's happening, obviously, right? Because you have now no coordinated breathing at all and respiratory efficiency is down. So what are the symptoms? What are things that you can observe in yourself? Things that you feel. I'm having difficulty breathing. I've just been in the water for 5 or 6 minutes and I felt perfect. Now I'm like struggling to breathe. For some reason, I feel like I got a problem breathing, right? And actually now feeling short of breath, which is a little bit different, right? Difficulty breathing means you're kind of feeling like you have to inspire heavy. Shortness of breath means you're starting to get a little bit weak from it, right? So lightheadedness. Again, 5 minutes into a dive, you're at 10 meters depth, shouldn't really be feeling lightheaded, but you got short of breath, lightheadedness, your anxiety and apprehension level now starts to skyrocket, right? Particularly in newer divers, right? Those of us diving a long time, you kind of know when that anxiety comes on, you know how to kind of stop and slow yourself down and take a few, good deep breaths and, think about worst case scenario planning and everything else that you've been trained for. But newer divers tend to have an anxiety that just literally goes up like exponentially, right? Because they're afraid now and they don't know what the problem is. They shouldn't be short of breath. They shouldn't feel lightheaded. Now they become really apprehensive. Obviously, confusion and restlessness. If you find that your cognitive decision-making all of a sudden is not normal. I normally could figure that out just fine, but now I can't even hardly think about what's going on. And coughing. That's a dead giveaway. I mean, a little bit of cough every once in a while is fine. We all do that underwater, right? But if you find yourself like really almost right coughing continuously, feeling like you've got congestion in your lungs, that's probably a dead giveaway that you've got fluid accumulation in there. And this is something that George had reported. A number of individuals who lived afterwards said that they thought something was wrong with their regulator and their regs were perfect, right? It was just that their inspiration pressures were changing and they became anxious. So signs are things you see in your buddy. Symptoms are something that you feel. So you should kind of know both of those things. Now, as a boat captain or as a buddy, it's always good now to kind of have a bit of preemptive information that you give. Jamie, you and I were going diving together today. If you're feeling like kind of a weird and coughing or something's not fine, we're just ending the dive and going up. No questions asked, right?
Yep.
And of course, your training tells you that as well, right? You don't need a reason to end a dive. You just say you're ending it and up you go. So preemptive dive briefing here is always a good idea. And it's not just because of boat captain, but this is just your buddy as well, right? You review your signals, right? What your dive plan is, what's our maximum rock bottom depth that we're going to go to, and what are we doing, who's leading, who's following. And if you're not feeling so great for some reason, you just call it, right? So I'm encouraging people to be a good buddy, both for yourself as well as your other buddy. So what do we do if we now figure we actually have a case of IPE? Most important thing is you need to get out of the water immediately. Forget a safety stop. Safety stops are always voluntary, right? They become part of diving now over the years. They never were before, but now they are, but they're not necessary as long as you're within your, no deco limits, right? You don't need a safety stop. It's a good idea, but it's not necessary. And that extra 3 minutes or so that you might spend at 15 feet might be the difference between your life and death if you're suffering from IPE. And I'm going to talk in a second about a case and how rapidly it went down and led to a fatality. Okay. So getting out of the water as soon as possible. Jamie, I'm not feeling so well. We're done. Up we go, right?
We go.
Okay, then we're going up and we're going right to the surface. Now, it's a little bit more challenging if you're technical diving and you're, needing to have a couple of deco stops on the way or something like that. You're in a little bit more precarious situation right now, but we're really talking about, not no stop wreck diving right here, getting out. Once you get out of the water, sit in an upright position. And that's counterintuitive to what we're all taught, right? In first aid. Not feeling so well, put you in recovery, right? Lay on your left side with your arm under your hand and whatever. But why do you think it would be better to sit up? You get the person and you're gonna sit up and gonna lean back. Why do you think that would be better?
Gravitational pressure of
Exactly.
the liquid.
You got
going to the
liquid in your
bottom.
lung. You'd like it to sink. Exactly. You want it to settle to the bottom and try to create cleaner airspace above it. Whereas if I'm lying on my side, now my whole lungs are going to be flooded with that fluid. So it's a bit counterintuitive to normal first aid. So having the person sit in an upright position, very important if they're conscious. If they're unconscious, of course, then now you're going to plan B, which is, are they breathing? Do they have a heart rate? Do I need to do CPR? Get a defibrillator on them, oxygen or whatever. But if they're conscious, getting them sitting upright is definitely the way to go. Oxygen administration, 100% of the time indicated to give, even if you're not sure, right? There's no reason why you would ever not give oxygen to a diver in this situation. And the benefit of oxygen in an IPE case is what? Increasing the partial pressure of oxygen in the airspace and the alveoli.
Fluid
You're
back.
pushing more oxygen across that semi-permeable membrane into the red blood cells, and you're trying to then reduce the level of hypoxia down at the tissue level, right? So oxygen is absolutely essential. Using a demand right is not a bad idea, but even better if you got lots of oxygen is 15 liters per minute on a non-rebreather mask. And a non-rebreather mask is typically one that has the little bag down below the bottom and one-way valves so that when you expire, you don't breathe back in any of the carbon dioxide that you breathed out, right? So you're not rebreathing your own expelled air, which means you get a higher oxygen level that you're inspiring, which of course is better than breathing back in carbon dioxide, right? So either a non-rebreather mask at around 15 liters per minute, but only if you got lots of oxygen. Now, it's always a critical factor, right? Most places.
Is that partly just because, again, a demand valve would be creating negative inspirational pressure, right?
Exactly. But it preserves oxygen longer, right? Yeah. And then if it's a demand valve, it's got a button you can push and you can help facilitate. And if the person's conscious, they can also aid themselves, right? Yeah. So kind of variable. Keeping the airway clear because it's going to be full of foamy, frothy sputum, maybe pink stained or whatever. You want to keep that clear. Keeping the person warm. Again, normally in first aid, we would always say, put a blanket on somebody to keep them warm. But in this case, keeping them warm is important because it aids vasodilation. So if I'm cold and my peripheral tissues are vasoconstricted, it's moving all that blood to my core. Whereas if I'm warm now, my vasodilation happens at the periphery of my body, gets rid of that blood volume out of the core, reduces blood pressure and blood volume, which then will help alleviate some of the symptoms of IPE. And don't give fluids. Again, every time I see somebody responding to first aid, they're like, here, have a drink, right? Have a drink. Worst thing you can do. Why? Because they might choke, for starters. A, they don't need to be more hydrated. They're not going to hydrate by, giving them a bottle of that anyway. And C, you're going to exacerbate the fluid volume in their system by giving them more fluids. So there's no indication to be given fluids. So no fluids, sit them upright, get them on oxygen, clear the airway, and get them out of the water promptly. That's a really important thing. If they're unconscious, and we're going to talk a little bit about a case here, but if they're unconscious, then you really have to go to a quick plan B, right? Are they breathing? Do they have a heart rate? Can you detect it? And I can tell you, I've done lots of first aid before. It's hard sometimes to even find a heart rate, particularly on somebody that's a little bit obese. You'll be feeling all around for it, and you get no heart rate, right? It's actually not as easy as everybody makes it believe. Well, just check here and we'll see if yeah, not that easy. A lot of even trained paramedics oftentimes, they'll just assume that they don't have heart rate. They can't find it right away, right? So CPR, if necessary, obviously at that point, it's a life-threatening situation. You have no choice but to do CPR. Getting them to a clinic right away, and at a clinic, the usual clinical response is to give immediate diuretics. That makes sense, right? You want to get rid of fluid. Vasodilator drugs, again, makes sense. Gets the blood from the core out to the periphery. Positive airway pressure rather than negative. So now positive pressure like a CPAP machine, right? And then that helps then drive the pressure across that semi-permeable membrane the other way and try to move that fluid out, okay? And then, of course, ventilation in an extreme case. So that's if the person's unconscious. Okay, let's just talk about a little case. And this is my own. And group of divers went in the water. Everybody was fine. All experienced divers, you know, intermediate level and better. Lots of experience, been on this dive before many times, no issue. Everybody jumps in, and 5-7 minutes after, one diver comes to the surface all by themselves. Nobody. And they turn around and I ask them if they're okay. And then they're about, 50 meters away from the boat at that point, right? Yeah, they're okay. Okay. It's kind of weird though, 5 minutes into the dive, they're at the surface all by themselves. That's kind of weird right away. So I'm on hyper alert at this point. And then I said, well, okay, let's get you out of the water, swim over to the boat here. They get a little bit closer and not looking too normal. And I go, are you okay? Yeah, I'm okay. Now I'm not really believing them, right? But they're telling me they're okay. So they're denying their symptoms, right? Again, classic. People deny symptoms, especially the cowboys amongst us, right? You want to be tough ass, so you just, yeah, I'm fine. I feel fine. Well, denying the symptoms. Get a little bit closer to the boat. Labored swimming now, right? Having difficulty getting coordinated on the back, swimming, a little bit of a current, a little bit extra workload, a little bit cardiac overload, because they're working against the current. And now I kind of hear like that, a little bit coughing, right? And I yell out again, you okay? Yeah. Now not so confident, right? And I'm like, where's your buddy? I don't know. Okay. So then keep coming to the boat, swimming, and gets beside the boat, and now in very obvious respiratory distress, right? Coughing like crazy, sputum coming out the mouth, grabbing at the wetsuit like this, which is a dead giveaway sign. I'm
Having trouble breathing.
Yeah, exactly, right? Like this. I'm pulling it away. Reg is just hanging down like that at the surface, right? Now I'm kind of like in hyper mode now because I know some shit's gonna happen. Get to the back corner of the boat, unconscious in the water. Went hypoxic within 50 feet of swimming, basically, right? Went from being able to kind of at least back paddle a little bit to being unconscious. So they went severely hypoxic. Now, a heck of a situation now, right? Got an unconscious diver, nobody, got to drag the person out of the water, CPR, defibrillators, oxygen for 30 minutes, and they never made it, okay? That was a fatality. Now, we're going to talk a little bit about some of the other issues here, and say people like Jamie might know the background on this, so I'm not trying to tell tales out of class. I'm trying to give you information to help you as a diver, okay? That's all it's about. And it was a kind of a classic case here. So this one ended up in a fatality to a diver that told me 3 times in a row that they were fine. How do you reconcile that, right? I'm fine, and then 3 minutes later, you're dead. Like, it's imponderable. They drowned, basically, from effusion of blood plasma, causing them to have respiratory failure, hypoxia, and then unconsciousness, right? And once you go unconscious in the water, outcomes generally not so good. So we're going to skip over this one. You talked, Brad, about this being around forever. One of the problems with IP is it was probably misdiagnosed 30 years ago as well. It was just, DCS or air embolism, and that's why they died, right? And in fact, that might have happened after the fact, but IPE was likely the precipitating factor, which caused panic, and, bolting to the surface because can't breathe very well. Something's wrong with my rig, got to get out of the water. And so now seeing that fairly well, like maybe a fifth of the cases, in fact, probably had a strong IPE underlying case. So whereas 30 years ago, it never would have been diagnosed, now it's kind of like that was the precipitating factor, which probably could have been avoided, right? Probably could have saved this life rather than not. So issue on that one. So the other thing here is, we're talking about divers when they come to the surface. Now, what happens if you're under the water, right? And you feel like you're having the symptoms, right, of IPE. Now, what do you do? Okay, Jamie and I are diving again. I'm feeling kind of funny, so I'm like, we're done, right? Going to the surface. So you end the dive immediately, begin your ascent to the surface. Relaxed descent. And this sometimes is hard when you're anxious, right? You just want to get the hell out of the water. But if you can have a relaxed descent, why? Because physical exertion increases the workload on your heart, increases the blood pressure and blood flow to the core, exacerbates the IPE issue. So you want to try to have a relaxed descent. You want to try to maintain very slight positive buoyancy. Why? Because we typically don't say, you want to be too positively buoyant when you're ascending, right? But the reason why you want to be slightly positively buoyant here is because if you go unconscious, at least you're going to get to the surface, right? Because if you're negatively buoyant and you go unconscious, you're done, right? So you can, if you're managing your buoyancy pretty well, you can kind of come up in a relaxed thing and keep a little bit extra air in your BCB to be a little bit positively buoyant. So you know that if you happen to go unconscious, at least you're going to float to the surface and you're better off there than sinking to the bottom, right? Keeping a horizontal trim, which again is not typical of more new divers, right? You always come up like this. You're swimming up the line, hanging onto the line and swimming up, right? But if you can maintain a nice horizontal trim, and of course, when you watch experienced divers and technical divers, we all do that, right? We're in the water like this and we ascend like that. We're finning nice and casually, nice and relaxed, and you come to the surface in a nice horizontal trim. Again, trying to reduce that differential hydrostatic pressure from your feet to your heart, right into your lungs. Horizontal trim. This one's really important, not just for IPE, but for everything. Focusing on a controlled in-out breathing, right? That some of the old training was always like, breathe out like that, make that kind of weird noise and all that. Actually, that isn't a good idea anymore. Just breathing normally keeps your airways more open than any other way. So just normal in, normal out, focus on that. The other thing is that I found in my early diving career, if you focused on your in-out breathing, it actually relaxed you, right? Because you're not thinking about the shitstorm that's happening. You're thinking about, right? And so it's very important that. And then this one here, key one. If you're with a buddy, stay with the person and get them out of the water. So in the example that I gave you, and I got to be careful here because I don't mean to be critical to anything or anybody, but in the example that I gave you, the diver came up alone after telling their dive group that they were fine. They were shallow, experienced diver. They were just saying, I'm going up, right? And they watched them go to the surface and inflate their BCD. So everything's fine. I'm going to stay together. But that swim back from 75 meters away, under that load, under a bit of a current, under anxiety that happened, right? That probably was what tipped the balance. If they had been together and I'm like, come on, I'll give you a hand back, right? I'll give you a little bit toe back. I'm going to help you. I'll just relax, flip over on your back, take it easy, breathe normal in and out. Might have got to the boat alive, conscious, probably would have saved a life. Because immediately would have been on oxygen, immediately been in an upright position, immediate call to the Coast Guard, would have had a clinical response right away, probably would have lived. Now, am I smart enough to say that was really what caused that individual to die? No, because you never know exactly. What I do know is that they came up conscious and alert enough to be able to respond to me. They swam less than 75 meters to the boat and were dead by the time they got to the back of the boat. And had to work against a current, breathing, whatever, right? So I mean, this is one thing I've seen change in diving a lot. Lots of people are solo certified and all that. Many of us are more self-sufficient and everything else. But if you're diving with a buddy, stay with your damn buddy. Get them back to the boat or to the shore or whatever, and make sure that they're okay. If everything's fine and you misjudged, the worst thing that happened is you just missed the dive. It'll be there the next time, right? Problem is, if you make a bad decision and you don't get them back and you don't stay with them, then you might have a fatality that you had some role in somehow, right? Maybe, And I mean, personally, I've had probably 4 or 5 like that, where I had people in emergency situations in fairly deep water, stayed with them, got them right back to the boat, towed them back to the boat, got them on oxygen, and never had a fatality. Now, did it make a difference? I don't know. They sure felt a lot more comfortable that I was with them. Somebody's right beside me and I'm holding on to them and I'm going, you're going to be okay, yada, 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 And standard first aid, right? So anyways, so be a good buddy. Stay with your partner. All right, quick recap. Obviously, avoid diving with known serious heart and pulmonary disorders. So if you feel like you're in that category, maybe time to see a doc and have this assessed, right? Have a look at that. Listen to your body and your head before a dive, and if you don't feel it, you feel it. That's kind of what we say. I'm not feeling it, right? Whatever it is. Sit it out, right? I mean, I'm like Brad. I've been diving for 5.5 decades, thousands of dives and all that. There's times when I'm just like, yeah, not today. I'm tired. I'm whatever. I'm not. People are like, well, whatever. And I'm like, yeah, let's go have some fun with somebody else, right? But I'm good. So listen to your head here. Obviously, this one I'm kind of, exaggerating this one here, but surface and get out of the water as quickly as possible at the earliest signs of respiratory distress, unusual fatigue, weakness, or coughing reflex, right? Because then you're kind of a prime candidate. And if you've made a mistake and you came out prematurely and it wasn't IPE, great. You're still alive and you can dive another day. If you push yourself and stay in the water and you go hypoxic and unconscious in the water, it's going to be your last dive probably. So these are kind of common sense things, but I don't always see them. As a boat captain, I've seen thousands of divers go in the water. You don't always see common sense prevail on things, especially the buddy system. I'll tell you the number of times buddy separation gave me heart attacks. One buddy comes back, the other one's like, I don't know where they are. Had 3 divers one time lost in different weekends on the Forest City in Tobermory. One buddy comes back, the other one doesn't. You know how much water there is out on the northeast tip of Bears Rump Island with a missing diver? I'm like, why did you not stay with your buddy? Well, they swam off like that and I was getting low on air. Really? Okay. Okay. Violated every principle of good, buddy diving, right? So the point of the matter is, don't take any of that for granted. Doesn't happen to just old and infirm people. Obviously, it can happen to anybody, Navy SEALs. So if it can happen to a Navy SEAL, it can happen to you or me. And don't just take them to the surface of the water and then let them go and go back down. Take them to the boat, to the shore, make sure that they're okay and that they're in somebody else's care at that point, right? So my take-home message are never deny obvious symptoms. Don't be a rock star. There's no point in it. There's always another day to go diving. So never deny obvious symptoms that you have them, and definitely respond early. Interestingly, of course, if you remember your gas physics, partial pressure of oxygen declines as you come into shallower water, right? Which is why you have shallow water blackout and free divers. But it also declines in a regular diver who's already in a hypoxic situation. So in fact, that last 5 to 10 meters to surface can be the critical points of making it or not, which is why you stay with your buddy and keep them positively buoyant, right? Because their PPO2 is going to drop fairly drastically as they get close to the surface. So I just wanted to finish with this thing on snorkelers because I have a listserv of anybody that wants to be on. I'm happy to add you. I sent an email around a few days ago about the increasing prevalence of IPE in snorkelers in Hawaii and Australia and a few different places. And you kind of go, really? What the heck? How is that going to happen? Snorkeling is thought to be pretty benign. Anybody can do it. But if you've been away on holidays to these places, right? Anybody that wants to get in the water and pay the money to buy a mask and whatever, they'll take you snorkeling. They're oftentimes older people, obese people, they're not comfortable in the water. They're straining against, wind and currents or waves or whatever. And a lot of them wear, these stupid full face masks, right? Which are known now to increase the amount of rebreathed CO2 because they got so much dead space in them, right? And they also increase the inspirational pressure as well, because they're not really designed for anything more than just being at the surface looking down in the water. But even at that, like I'd never wear one ever, right? And a lot of places now that do snorkeling, they don't allow them and they don't rent them.
They've been banned in Hawaii, I think.
And they've been banned in Hawaii because they've had actually several fatalities of snorkelers with IPE. That used to be just drowning. They thought, well, they drowned, right? But they didn't drown. They got into breathing difficulty and then they drowned internally. So the type of gear can be an issue there. And I guess I just tell you this because, lots of us travel around the world and you go and, you might see people snorkeling. If you observe somebody with respiratory or breathing difficulty and they're snorkeling, now you know what to do, right? Get them back to shore, tell somebody, get them on oxygen if you can, and stay with them, right? So that's the end of that. That was a little bit of a primer on immersion pulmonary edema. So I hope you kind of understand some of the physiological principles and anatomical principles that can predispose to this. Most importantly, recognizing the signs and symptoms, right? Things in yourself, things in your buddy partner that you can see. And you now have some tools to be able to know how to respond as well. Okay, so I think we'll wrap it up there. If you got some questions, ask them. That's a beautiful sunset in Tobermory, looking out from the tugs. Anyway.
Questions, anybody? I'm gonna just open the chat on the thing here in case. But
Except Kristen, she can't ask me.
Potentially stupid questions, so I apologize. But if you don't have oxygen,
Yeah.
nitrox is still
Sure.
better than nothing.
Still a little, absolutely better than nothing, right? And of course, you also have the advantage that you can press the button and help somebody breathe, right? So, yeah, 32% is better than 21. So good.
okay, so we did have a couple. Are
Oh.
the symptoms more gradual or sudden onset? Would a diver recognize something's happening with their breathing and be able to make an ascent, or is it so rapid there's no time to react?
No, typically they have time to react. The symptoms, although they have fairly rapid onset, as long as you respond early on, then yes, you're usually able to recognize it, make a controlled ascent, get to the surface positively buoyant, right? And then, of course, the other thing is once you get to the surface, you now at least don't have to be breathing against your reg, right?
Yep.
And then you're closer to support. So good question, Polly. But yes, typically you have time to recognize and respond.
Next one was, would it make a difference swimming on your back or your stomach if you had to swim from 50 feet off the boat back to the boat? Does it make a difference? And I'm gonna guess the
that's a
answer is
Good question. I actually don't know the answer to that. My logic would tell me it probably doesn't matter. What matters is get to the boat.
that horizontal would be better than
And
vertical at this
horizontal
point.
better than flopping around vertically in the water, right? Which of course is the more common thing too, right? When you come to the surface, you're usually just bobbing this way. Whereas, if you feel like you have an issue, flip over on your back, get positively buoyant and swim on your back, then you're keeping yourself more horizontal.
I think people tend to think vertical is better because your head's gonna be up out as opposed
Yeah.
to this way where your head be closer to the water.
It's funny in the
Well,
early days of the Navy diving, a lot of the docs used to tell them if they felt symptomatic for DCS to come up feet first. And that kind of went out of favor, but actually it ended up making some sense because it changed the hydrostatic differential pressure from your head to your feet, which would then help to kind of get rid of a lot of the fluids, right? So, I mean, it's sort of a ridiculous thing that you can't really do most of the time, but with Navy divers back then, it was all wetsuit divers, so you had more ability to flip over, and they would say, maybe be better to come up, feet up, or even just head down a little bit, right? So, yeah.
Just, you talk about get the boat quickly, but in the case example that you had, was it the 75-meter swim that did him in? Would he have been better just to put up an SMB and float there and let somebody come to him? Would the symptoms have potentially cleared up on their own? or not have gotten
Yeah.
as severe?
Well, so you present a couple of different interesting questions in that. They already were obviously pretty hypoxic, right? So the longer they stayed away from getting oxygen, the worse they would have become, because they already were pretty severely impacted. So throwing up an SMB and just floating on the surface, presuming that somebody could come and get you, there was no way to do that because there was just me on the boat and one crew. I can't, not sending somebody in the water to swim back and nobody around. So I would say in that case, trying to swim more gently back to the boat rather than try to fight the current or whatever, to try to be as relaxed as you can. But it's a critical thing, right? There's only so much time you have before you go enough hypoxic that you go unconscious, which is what happened. So, and there was nobody to do a recovery. I mean, it's a tough thing as a boat captain. Like if somebody's, a few meters away, I might jump in and pull them back. But more than that, no way. It's just too bad to say it, but
Well, one of the big challenges, quite frankly, and most of us probably recognize it without actually saying it, is you think, oh, there's a diver, he's 250 pounds in doubles in the water. You're not getting him out of the water anyway.
not a chance.
That's one of the biggest issues, unless you got a crane, which most of the boats don't have. We've seen it. I've seen it many, many times with divers in distress. You can't get them on a boat in their gear. So it's one, cut off the gear or get it off first. Most divers don't want you to do that. So they'll say, oh, I'm fine, because they don't want you cutting off their gear, which I get sort of the logic, but the reality is, even if you get the gear off, a 250-pound person trying to hoof them up over a ladder at the back of Deep Obsession or any of the boats in Tobermory or any of the liveaboard boats I've been on, is almost impossible.
I couldn't budge the person with gear on. I cut the gear off, right? I always wear a serrated knife and cut both harnesses off, dump the gear. And that, I still needed an extra pair of hands to drag them up. And they weren't a big person. Like, they weren't.
Yeah.
Like,
Isn't that what
they
those
weren't 190, 200
for?
pounds or whatever. But yeah,
Thank you so much.
so,
Thank you so much.
okay, thanks. Yeah, good to see you again.
Thank
Yeah,
you.
you take care. Yeah. So, yeah, I don't know if that answered the question or not, but anything else online?
Well, one of the other ones was, once you've had it once, are you predisposed to getting it again? Or is this just sort of more a situational type?
Yeah, the conventional thinking is that you're probably predisposed, and that if you have it once, you've got a higher likelihood of having it again. And, George Harper, if he was here, he would tell you, if you've had it twice, you probably should consider quitting diving, because your time is coming.
So maybe on that, so let's say somebody like you or I've been diving for 20 years, never had an issue.
Right.
Is it likely that I'm still not ever going to have an issue, or because of those predisposing factors, aging and all that stuff?
Exactly.
Because I think that would be one of the things that most of us would think, oh, I've been diving for 50 years. I can't have that problem.
100%.
I've never had an issue. And that is almost helps cause the denial of those things. Oh, it can't be IPE because I've never had it before.
Right.
And I've been diving forever.
I mean, when's the last echocardiogram you had? I don't want you to answer me, but I'm saying.
This week. Full physical. Okay.
Anyway, but the answer to that is no.
Yeah.
Prior history is important if you've experienced it before. It's not really that relevant if you haven't.
Yeah.
Because you have all these growing predisposing factors and underlying comorbidities or other medical issues, right? So, so I guess it's just the kind of thing like diving is more risk than sleeping on your couch kind of thing. The important thing is, if you recognize symptomatically something, respond to it rather than, deny it and dive another day.
I might be wrong on this, but my understanding is unless I take another course, I'm never gonna get asked to do another medical for diving. Should there be, at a certain age, frequent medicals? And is there a criteria that you'd be looking for in that medical, such as a MET score type of thing
Right.
from a,
So METS is a metabolic equivalent measure of your cardiovascular aerobic efficiency, right? So to get what's that?
Thank you, some of us didn't know that.
Yeah, sorry. Well, that's why.
I know that because I've had.
Yeah, so-
coronary.
Right. So like, for example, to get a commercial diving medical, you have to meet a minimum of, I think it's 15 or 14 METs. And they measure that by putting you on a treadmill that gradually increases in angle. And you run on the treadmill until you basically puke or your heart goes off the map and they stop you, right? And then on the basis of that, they can calculate what your metabolic equivalent of your aerobic efficiency is. So an athlete would have a higher MET than a, very overweight person that sleeps on the couch all the time. So I didn't answer your question because I guess it depends on each situation. For recreational diving, the fact is most medical doctors don't really know a lot about the diving environment. So you really need to speak to a diving physician, which is why we've relied so heavily on somebody like George Harper, right? Because he's got 60 years of working with divers and that. There was an interesting case just published yesterday on the Dan newsletter of a highly experienced diver that had a DCS episode, and they found out after he had like 3,000 dives that he had what's called a foramen ovale, which is a hole between the two chambers of the heart, and it allows gases to short circuit across the heart and not go to the lung, and then ended up with a DCS. And his first doctor's visit was they did one test and said, no, you don't have one. And then another physician was kind of like, you might want to do another type of evaluation, called the transesophageal test. And they actually found that he had a open foramen ovale, and they were able to repair it. They can go in actually and stitch it back up, right? Everybody's born with one. It's like a hole in your heart a little bit between, and I don't know, 15% of people as adults still have it. It doesn't fully close, right? It gets smaller and smaller. So then that's another predisposing factor to DCS especially. And, I guess if you're working with diving, if you're, like in my case, I'm a scientific diver. So every 2 years I have to have full diving medical. I'm kind of at the end of my lifespan on that now, because they put you through that kind of testing. But for recreational diving, I guess everybody has to make their own call. If you feel you're physically fit and you got, good ability to be physically stressed and not, breathing heavy going up a half a flight of stairs, then, take it easy, shallow, warm water, stay away from heavy currents, cold water, dry suit diving is much harder on your system, obviously. So there's ways to adapt, I guess. Well, I can't answer your question because it's a very individual thing, but
Tammy and I are seeing more operators asking me to do a medical before you dive with them.
I think the one in Iceland said if you're over the age of 60, you're not diving with this.
In Iceland, they even have height restrictions. If you're less than 5'4", you can't dive Silfra, for example. I just had a young lady that was in here she's 4'8", and they denied her diving, just too small. For whatever reason, but a lot of places are asking for medicals just to have you board the boat or dive at the resort.
Probably insurance, right?
Insurance and liability, they just don't want the culpability. Yeah.
At the end of the day, I guess my message is IPE is still relatively uncommon, but it's occurring more now than it has in the past. We recognize the signs and symptoms of it. We have a treatment protocol to address it if you recognize it, which can save your life. If you ignore it, you might die from it. And it's got a bunch of variables which create more opportunity to have that now in divers because of all these other variables, older divers, comorbidities or whatever. So that is something that's major different now than 40, 50 years ago, right? Is definitely that. So I'm not trying to scare anybody, right? And not like you go out there now, you're worried you're going to have IPE and die. I'm not saying that. But if you go out there and you start hacking and coughing in the water and you're feeling like you can't breathe very well, kids, get the hell out of the water, right? Come to the surface, dive another day. I mean, I had another good friend that had a near fatal IPE attack in Newfoundland and kept diving afterwards, and then ended up, dying with a heart attack in his sleep because he had such underlying cardiac pathology. That was what triggered the IPE, and probably at that, because he almost died from the IPE originally, probably should have quit diving. But he'd been diving for 35 years, technical diver, like, thousands of dives, never wanted to give up diving. There you go. So anyway, we're all gonna go out somehow, so I guess, yeah. Well, it's true, right? I mean, I raced motorcycles semi-professionally for 25 years and saw lots of people die on the racetrack, and I kept doing it, but you know, you gotta make your own calls about what risk you take and what you don't, so anyway, there you go.
Thank you, Rich. So Rich said, you know, he's got some key takeaways. He had his. I have my own just from having listened. One is Mike is your friend. Now, Mike's our regulator technician. And as our regulator technician, you know, Mike and I see all sorts of divers coming in here with gear that's probably been around as long as George Harper's been working in Tobermory.
Yeah.
Regulators from 1974. And a number of years ago, we just refused to work on them anymore. Yeah, we could, but we're not going to, because that's so old technology. That's like
Yeah.
saying, hey, I want a modern race car in a Model T Ford, you know, with a wind up rubber band at the front. Like, it doesn't work. It's inconsistent with the goal.
Right.
So one, Mike is your friend. Two, the whole idea of the buddy system just is reinforced by this, because you could be saving somebody's life. I don't advocate for solo diving, never have. I get it. If you want to do it, you're taking your own risk. But the number of people that I hear, having been in the industry a long enough time, that died probably unnecessarily because they weren't with a buddy for a variety of reasons, rebreathers, technical, IPE. I think, wow, there's a lot of people that would still be here if they were diving with a buddy. So
I'm convinced in the case that I had, that had the buddy come and towed them back, it would have got to the
Person
boat
would've lived.
conscious and probably could have saved their life.
Yeah.
Cause that 1 minute of unconsciousness, you know, that was the point of no return, so yeah.
So being a good buddy, and as Rich said, like, I'll be the first one to say, oh, no, they'll say, oh, you go back dive. No, I'm staying with you.
Yeah.
We'll just sit in the boat and talk. Yeah, that's fine. But I want to make sure you're out and you're good.
Right.
If we did one of these on a dive, there's a reason for that. And I don't know how serious that was. It's just that. So being a good buddy is important. The other thing, and this may sound self-serving, take the oxygen provider course. If you have not, you know, I don't care whether you take it with me, do it at Blue Heron Adventures, do it at your local dive shop, but take the course. I've been long advocating, hey, if we're gonna dive together, you better know how to save my ass, because I could be the one that's in trouble.
Yeah.
And I don't want to be in trouble if we're at Wyerton and you don't know what to do. And how do I assemble this O2 kit? I have no idea. That could make the difference between me living and me dying or having some serious injury. So certainly that as another, you know, key takeaway. It's not hard to learn how to save somebody's life. And
Basic
well worth doing.
stuff like that is important, right? Even, you know, if you ask somebody to go and get an oxygen kit and put the rag on, if you haven't done it, they're like fussing around for 10 minutes because they can't figure out which way it goes on and how to get whatever, right? Take this course, like you got that down pat. And there's almost never a situation where oxygen administration is contraindicated. Like, unless you got an open flame or something like that, but otherwise, like, it's never a bad thing.
And then the last thing
That's
I'm gonna say is the deniability of symptoms is probably the biggest contributor to a number of these real serious things. And I've lived through it myself. We were a couple years ago in Truck Lagoon. We'd been diving off the skiffs and it was really hard to get onto the boats with my doubles. And I've been smashing here because of waves. Okay, and so I was sore in my chest area. And I got out of maybe the third day on our dive trip there, and I noticed I actually had some bruising
Wow.
here. But I thought, could be skin bends,
Yes, could be.
because, you know, I hadn't done really anything, but we've been doing some deep diving. So I sat out for a day, went on pure oxygen. I went and told the captain, hey, I just noticed these now.
Perfect.
I'm staying out. You guys go ahead and enjoy your diving. They didn't go away, which we knew they were bruising, not skin bends, blah, blah, blah. Okay, fine, keep going. That
That's
was
good.
all
though.
good.
Yeah.
But as the shop owner, as the leader of the trip, I had to be the one to put up my hand and say, I could have a problem. And I was the first one to do that. And I'm going to encourage everybody listening now or in the future on the recorded version, don't be afraid to say, I could be having a problem. I didn't do anything that was wrong. I did what I was trained to do. It just affected me that way differently that day, or could have. That wasn't a Ben's issue, but it could have been. I've sat out many dives when my equipment wasn't working, when I didn't feel it, when I felt nauseous because I was on a boat and I get motion sickness. I've sat out lots of dives.
Yeah.
You just have to be afraid, not be afraid to say, hey, I'm not feeling it today. And especially if you're feeling something. Up in Tobermory, we had a guy on one of our trips. Did the Arabia, been on it a million times, did a 14-minute dive, which is not long, on 32% nitrox. By the time about 5 minutes later, I hit the boat, as I'm apt to do, I ask everybody, hey, Rich, you feel okay? Michael, you feeling good after the dive? Todd, you're good? Tammy, you're good? And he said, you know what? I tweaked my back getting up off the ladder. I said, what do you mean you tweaked your back? Nah, I got pins and needles back here. Yeah, kind of feeling a bit numb. Anyway, it turned, he had a spinal hit, and we got him on O2 and got him, Coast Guard came, and we could have saved his life because the spinal hit was pretty serious. But he wasn't going to volunteer it because he wanted to deny his symptoms. He wanted to say, hey, I'm feeling something that's not normal, but it's because of something else. He didn't do anything wrong. We looked at his dive computer and he had a PFO and had been diving for years and didn't know it.
That's an open foraminal valley. Patent is term for
Patent
open,
for
right?
Foraminal Valley.
PFO, yeah.
So he had a PFO, but had been diving for 20 years
Yeah.
and it had never presented itself. But that day, for whatever reason, the variety of things that came together, and he told us afterwards, I was kind of tired. He was sleeping in a tent in Tobermory instead of a hotel. He had a few beers with his buddies the night before, and then a few coffees in the morning after to recover, all of which are diuretic, dehydration, blah, blah, blah. And he was getting older, and so it just happened to hit him that day. But had we not asked, he wouldn't have said anything and he could have ended up dead.
Yeah.
So don't be afraid. If you feel something abnormal after a dive, say something, because somebody can help you. The worst they can do is put you on O2 and you go, hey, I feel better already.
Yeah.
You know, like it's not gonna get any worse. Nobody's charging you, but for the O2 you use, it's good for you.
And you can do everything right, follow every rule, follow all
Still
the
have an
books and
issue.
still have a DCS hit, right? Completely unexplained, you can't figure it out, but I've seen it dozens and dozens of times, you know? My computer was fine, my center rate was fine, I felt fine, still had decompression sickness, so it can happen. And recognizing it and responding to it rather than denying it, right? Yes. Good point, very good.
Let me just make a comment. I've always done many trips with you,
Yes.
including Tobermory many times. I always appreciate the fact that you, or whatever the boat leader is, go around and ask before and after the dive how we're feeling. Because I think that encourages the culture of not ignoring stuff that's going on. So, we'll keep it.
I just learned early on it's important, and it was important to me, and I like it when Michael usually asks me, well, Brad, how are you doing? Because everybody says, oh, Brad must be asking everybody, must be okay. I like it when Michael asks me, are you still okay, Brad? Yeah, I'm good. So, Rich, thank you very much.
My pleasure, yeah.
For anybody that wants to join us and maybe keep chatting, Rich and I are gonna head over to Jack Astor's just around the corner. So if you'd like to join us, please feel free to do so for a beverage and some chat time. Nice to have a little social downtime afterwards, so please feel free to join us. And
If you see me crying, it's because the Habs have lost.
they'll have it on over there.
Or they will.
I'm sure they'll have it on over there. But thanks very much again for coming, everybody. And if you have any questions about any of the stuff, I touch base with Rich a lot. So if you have any questions you think afterwards, let me know. I'd be happy to float them to Rich.
Yep.
If you need an O2 provider home base, we have courses running all the time through the year. So please let us know. And aside from that, safe diving and enjoy the season. We're about to embark on it.
Have fun. Thanks for coming, everybody.
Yeah,
Take care.
yeah. And I will post this video, so if you do want to share it with others or